Hi, my name is Colleen Dussex, and I'm doing my case study on pulmonary embolism. So for part one, Mrs. D is a 71-year-old pleasant Caucasian widow who admitted to the hospital from the emergency department complaining of abdominal pain for 1 week. Mrs. D is a pleasant, alert, and oriented woman who looks young for her age and admitted for a GI workup. Her past medical history includes atrial fibrillation, treated with an ablation therapy in 2010. She remains in an atrial fib rhythm. She also has a history of DVT in 2008, CVA in 2012, no residual effects. Her NIH is 0. She also has a history of hypertension, hyperlipidemia, GERD, and at day 1, her admission, her INR level is 2.8. So for patients who are taking Coumadin, we would like their INR levels to be between 2.5 and 3.0 for coagulopathy. She has a white blood cell count of 11.96, which may indicate infection. It's elevated. Her hematocrit and hemoglobin was 8.6 and 26.4, which is low, which she could be losing blood somewhere. She could be anemic. She's a non-smoker. She's never used alcohol, and she has a BMI of 26. She's in good health for the past 3 years with no admissions. Her current medications include Coumadin, 7 milligrams daily, amiodarone, 200 milligrams daily, Lipitor, 40 milligrams nightly, Protonix, 40 milligrams daily. The initial exam shows that she's in mild distress, complaining of nausea and anorexia. Her skin is pale and dry, but quick to return to normal state. Her posterior and anterior lung sounds are clear with no nodules or lesions, equal and expansive and symmetrical. Her rhythm is atrial fibrillation, and it's irregular. Her belly is soft with right upper quadrant tenderness. Her bowel sounds are audible and active in all quadrants. Her last bowel movement was today. Extremities, she has no pitting. Her distal lower extremities are pale with decreased pulses. Bilateral hands are cold to touch. She's admitted for a GI workup. The Coumadin is going to be held for her colonoscopy, her upper GI, and she's also going to have a CAT scan and a hiatus scan completed to make sure she doesn't have gallbladder disease. All procedures were unremarkable. Her urine cultures did grow gram-negative rods, so she's going to be started on an antibiotic for a urinary tract infection. She's set for discharge in day 5, and her Coumadin is restarted with a Levinox bridge. Now, Mrs. D has several factors that put her at risk for a blood clot or pulmonary embolism. Her primary factor is that she's had one in the past. Second factor is she has atrial fibrillation that impairs blood flow and increases the risk of clot formation. She's also been sick in the hospital for 5 days, which gives her acute illness inactivity. She has decreased activity due to her abdominal pain, which could increase her chance for having a clot. And she also has coagulopathy. For stopping the Coumadin for the procedures could cause a rebound coagulopathy, resulting in a low INR and decrease clotting times, increase for risk for blood clot. Where her INR was 2.8 on admission, it is now 1.04. Mrs. D states she's pain-free and in good spirits. I can't wait to sleep in my own bed. Patient is up with physical therapy prior to discharge with standby assist of 1. After 20 feet, the patient hesitates, collapses, and displays seizure-like activity. Patient is pulseless with agonal breathing. Quality CPR is initiated immediately with bag-mouse valve. Cardiac rhythm is PEA. The patient's intubated. Central line is initiated. Return of spontaneous pulse after 4 rounds of epi drip initiated. Bedside echo shows a flattened left ventricle, enlarged right ventricle, which is positive for massive pulmonary embolism. TPA is administered within 15 minutes of collapse. Her ABG shows metabolic acidosis at pH of 7.04. Her CO2 is 57, elevated, related to the CO2 retention and acidosis. Her PO2 is 117, elevated from overbagging. Her bicarb is 15.7. The patient is placed on Levophed because she has very low blood pressure of 70 systolic. TPA to address her clot. And then after the TPA is completed, she'll go on to heparin. Patient is moved into the unit and placed on Arctic Sun. Arctic Sun is an apparatus that they put to cool the patient's temperature from 32 to 34 degrees, and it slows down metabolism and it protects the brain from damage due to the cardiac arrest. 6 hours post-resuscitation, the patient shows purposeful movement, and it's able to follow simple commands, squeezing a hand while she's under the Arctic Sun. At that point, they sedated her. ABG is now 7.3 pH, which is within normal limits. 24 hours post-resuscitation, the patient's rewarmed. In part 3, day 8, the patient is extubated. She's pale, fragile, and weak, but she's talking. Her skin is cool and waxy, with multiple bruises and petechiae. She's drowsy, easy to wake up, able to alert to her name and place, knows the month and the year, but requires assistance today. Her Glasgow Coma scale is 14. Her NIH scale is 3 because she's got some confusion and she has some drift in her left arm and her left leg. Her chest shows extensive bruising with multiple rib fractures. Breath sounds are decreased with coarse crackles. Her heart remains in an atrial fibrillation rhythm and is irregular. Her belly is soft and tender with hypoactive bowel sounds. Her extremities now feature 2+ pitting edema bilaterally. Her white blood cell count is 12.2, which is related to the immune response from cell injury, related to the hypoperfusion, ischemia, and cell death. The RBCs is 2.42 with a H&H of 7.4 and 22.7. The patient is diluted from the fluids, and she also is got a bleed related to TPA administration with extensive bruising and rib fractures. Her potassium is 4.1. When the cells experience damage, they release potassium. Her BUN is 38. Her pre-renal kidney damage due to hypotension, hypoperfusion, cardiac failure, and pulmonary embolism. Failure to restore the blood pressure and oxygen delivery can cause the ischemia and the cell injury and acute tubular or interstitial necrosis. Her GFR, according to the rifle, she has 11, shows acute kidney dysfunction because her decrease is greater than 50%, but the creatinine is 3 times what it was prior to her arrest. It's kidney failure, but it's not loss or end-stage kidney disease because it's only been days, not weeks or months. The patient is going to undergo hemodialysis, is improving daily, is alert to self, place, and situation, recognizes her family, is able to talk, but tires quickly. According to the treatment, the patient received high-quality CPR within 5 seconds of arrest. The American Heart Association says that if the patient receives in the first few minutes of cardiac arrest, it triples their chance of survival. Using TPA, according to Thomas, Chaucer, and Moore, significantly lowers the patient mortality in half, according to patients only receiving heparin. Pulmonary perfusion is also improved to 14% compared to 1.5% on patients only receiving heparin. In the study that they did that incurred over 50 patients, no patients that received thrombolytic therapy had a reoccurrence of a pulmonary embolism during their stay. When the patient was placed on Arctic sun cooling system to induce hypothermia, the Arctic sun cools to 34 degrees, 54 minutes faster than traditional methods, and it's more consistent on its temperature. Using therapeutic hypothermia after cardiac arrest decreases mortality by 25% and improves neurologic preservation and recovery by reducing metabolism and allows the body to recover from the trauma of cardiac arrest. The patient is rewarmed after 24 hours, showed purposeful movement and following direction. It was a success. The patient outcome and impact on practice. All her risks for pulmonary embolism came together in a perfect storm. She's lucky enough to have it happen in a hospital setting. If she'd thrown a clot at home or in her car on her way home, it would not have been survivable. Although she's still got a long way to go in her recovery, I've seen her smile and recognize me, and I thought that would never happen. Her neural functioning is at baseline, but her kidneys are severely injured. She's on dialysis now and doing well. I don't think there's anything that we could have done to prevent her kidney failure during the resuscitation. The impact on my practice is I will watch the anticoagulopathy levels more closely with patients who have been on Coumadin and have held. I come from a small regional hospital that did not have the ability to cool or diagnose bed-sized embolisms or treat with thrombolytics. I learned a great deal from this case. Mrs. D's survival and positive prognosis is evidence-based practice that will continue in our hospital setting. Our time frame for CPR, thrombolytics, and cooling were all critical for achieving a positive outcome. On a side note, she had 3 really good days, and then I just heard today and went to see her that she's having multi-organ failure. When she had her cardiac arrest, the blood flow did not perfuse enough to maintain healthy organs, and there's ischemia, and the ischemia was extensive enough that she had tissue necrosis, and it doesn't look like she's going to make it. Thankful that she had the opportunity to talk to her family before she passes, and I'm thankful for us to be able to learn so much that we did, and it is still a positive experience with a sad ending. Thank you.